Hi, everyone. Welcome to the session 20 in our 2024 webinar series, which has been entitled Empowerment Through Education. My name is Keith Fargo, and I'm the Director of Scientific Initiatives here at the Lewy Body Dementia Association. This is our final webinar for 2024, and we're very thankful for you for your support and participation in the webinar series this year. There will be a survey launched at the end of the webinar to ask you for your feedback, which we value very much. But I also want to let you know that in addition to that post-webinar survey, Rose, our colleague here, is going to drop into the chat a link for a year-end survey to fill out at your convenience. This survey has 13 quick multiple choice questions about the LBDA educational programming. And again, it's a great help to us as we continue to plan for 2025 if you can provide us with your feedback. We will also be emailing these surveys out next week along with the recording of today's presentation. So if you don't get a chance to get to it today, you'll have another opportunity next week. So we're going to shift now to a topic that most of us are interested in, and we're going to be learning about the similarities and differences between Lewy body dementia and Alzheimer's disease. So Lewy body dementia, just briefly, is a common form of dementia associated with the accumulation of deposits of misfolded proteins in the brain. And in terms of how common it is, it's second only to Alzheimer's disease. Furthermore, many people with LBD have some symptoms and some brain changes that are also associated with Alzheimer's disease, and vice versa. So in today's webinar, we're going to explore some of the aspects of LBD and Alzheimer's disease, take a look at how they overlap and how they differ from some of the most common symptoms to the shared and distinct brain changes that are associated with these two diseases. Before we meet today's presenter, though, I do want to give you a few words about LBDA. We are a nonprofit dedicated to optimizing the quality of life for those affected by LBD. We provide comprehensive education for the community and for professionals in events like this. We deliver compassionate support to those living with LBD, and we strive to advance awareness and research. Just a few quick housekeeping items before we get started. If you're interested in closed captioning, you can select the button that says Show Captions, which you'll find at the bottom of your Zoom toolbar. And you can do that at any time during the webinar. There's also a resources icon on that same toolbar that has links to downloadable resources to accompany today's session. So I encourage you to take a look at that. If you have questions during the webinar, we encourage that, and we welcome you to submit those questions at any time throughout the presentation using the Q&A icon. So remember the Q&A icon to submit those questions. And then following Dr. McLean's presentation, we will address as many of those that we can get to from the audience. This presentation is being recorded, and an email will be sent to those who registered with a link to view the recording in about 1 week. All of our webinars, including this one, are uploaded to our YouTube channel, LBDA TV, approximately 1 week after the live event. Lastly, when you leave the session today, as I mentioned, a brief survey will appear asking for your feedback about today's presentation. And we do encourage you to take a moment to complete that survey. And it truly does help us inform our future content. We take all of those very seriously, and we read each and every response. Now, let's learn more about who is joining us in the audience today. Rose is going to launch a polling question that you can answer. Thank you very much, Rose. I will say if you're watching with another person, you can feel free to choose multiple answers on that poll. So let's see who's with us today. All right, it looks like we've got people with LBD or LBD symptoms, care partners. This includes spouses, former care partners, healthcare providers, family and friends, and researchers and scientists. And you can also select other if you don't feel like any of those categories are the best fit for you. All right, thanks a lot. So let's go ahead and take a look at some of those results now. All right, Rose, are people able to see the results? I'm going to assume that's a yes. So it looks like we've got about 30% of people joining us today are folks who have LBD, or who have symptoms of LBD. About 60%, so about 3/5 today, are people who are care partners, including care partner spouses. About 10% are former care partners. About another 10% are family or friend of someone with LBD. We have about 5% of the participants today who are healthcare providers, and about 3% who are researchers or scientists. Falling in that other category, so you've told us that none of these categories are a great fit for you, about another 10%. Thank you very much for responding. All right, so now what we're going to do is we're going to meet our presenter for today. Pam McLean, Ph.D., is a professor of neuroscience at the Mayo Clinic in Jacksonville, Florida. Dr. McLean's research focuses on understanding the cellular and molecular mechanisms underlying neurodegeneration in Parkinson's disease, dementia with Lewy bodies, and related neurodegenerative disorders. Her research uses state-of-the-art cell-based assays, novel imaging techniques, and preclinical models to investigate the role of alpha-synuclein, which is a protein that misfolds and aggregates in the brain regions that are involved in these diseases. Dr. McLean earned her Bachelor of Science in Biochemistry from the University of Glasgow in Scotland, and her PhD in Pharmacology from Boston University here in the States. She also undertook postdoctoral training at Massachusetts General Hospital and Harvard Medical School before moving her research program to the Mayo Clinic in 2012. Dr. McLean has published over 110 peer-reviewed publications in medical journals, and her research is supported by the National Institutes of Health, the Michael J. Fox Foundation for Parkinson's Research, the American Parkinson's Foundation, the American Brain Foundation, and the Florida Department of Health. Pam, thank you so much for being here with us today.
Thank you, Keith. Thank you for that great interaction. Hello, everyone. Let me just start by sharing my screen and put this in presentation mode. All right, I'm trusting everyone can see that properly. So yes, thank you for that introduction. As Keith said, I'm Pam McLean. I'm a research scientist at the Mayo Clinic in Jacksonville, Florida. And today I'm going to try and talk to you a little bit about what is going on in the brains of patients who have Lewy body dementia and related disorders. And so let me just move on to my first slide here. Okay, so what our objectives are for today is hopefully you will leave today's webinar being able to name 2 or more proteins that are implicated in the development of Lewy body dementia or Alzheimer's disease. Hopefully you'll be able to compare and contrast symptoms of Alzheimer's disease and Lewy body dementia, and be able to identify at least one commonly shared symptom and one symptom that's usually distinct in each disease. And then finally, hopefully you'll be able to recall that having brain changes that are associated with both diseases is actually very common for most of us as we age. So the term dementia is really an umbrella term, and it's used to be it's associated with a range of diseases where the major symptom is cognitive impairment. And as Keith said in his introduction, the disease most of us think about when we think about dementia is Alzheimer's disease. However, there are other forms of dementia out there, often vascular dementia, which presents very similarly to Alzheimer's disease. And then Lewy body dementia and frontotemporal dementia are other types of dementia that we see in patients who suffer from cognitive decline. So let's talk about Lewy body dementia. So if you think about a spectrum of diseases, and at one end of the spectrum, you have Alzheimer's disease, and at the other end of the spectrum, you have Parkinson's disease. So when we think about Lewy body dementia, it comes in between. It's kind of on the spectrum between Parkinson's disease and Alzheimer's disease. So Parkinson's disease, as we know, is primarily a movement disorder. So you think of it as the patients are afflicted with having trouble in some movements. Alzheimer's disease, on the other hand, we know is affecting memory primarily. Now, in between these two diseases, we have dementia with Lewy bodies, which primarily presents with cognitive impairment. And we have Parkinson's disease dementia, which arises in patients who have Parkinson's disease, but then go on to develop dementia later on after years of having Parkinson's disease. And so together, the Lewy body dementia actually includes two clinical diagnoses, which are dementia with Lewy bodies and Parkinson's disease dementia. All right, so before we can talk about what's going on in the brain, let's do a little homework on your brain. So if we look at the brains from the outside, you can see the different lobes that are the frontal lobe, the parietal lobe, the occipital lobe, and the temporal lobe, as well as the cerebellum, which is found at the base of the brain. If we were to look inside the brain, the regions that are relevant to this talk today are the brainstem region, the midbrain region, and the cortex, which is at the top of the brain. And then I also refer to a region of the brain that we call the limbic region. And the limbic region is a term that we use to include a number of different regions of the brain that are found just above the midbrain. So then let's look at what's going on in the brain. So at the turn of the 20th century, Dr. Alzheimer described what he was seeing in the brain of a patient who had cognitive impairment after they had passed away. And what he saw what we now call amyloid plaques and neurofibrillary tangles. Now, amyloid plaques are aggregations of protein called beta amyloid that actually accumulates outside of cells in the brain. Neurofibrillary tangles, on the other hand, these are made of a protein called tau, and tau is a protein that is involved in transporting molecules up and down the processes of a neuron in the brain. And what happens is when something goes wrong with tau, it dissociates from these microtubules and it aggregates inside the cell. And if we look inside the cells, inside the brains of patients who have Alzheimer's disease, we will see these hallmark neuropathological changes. And when I say neuropathological changes, I just mean that changes that are happening to the structures inside the brain. And so these are your amyloid plaques containing amyloid beta protein outside of the cells in the brain. And then these are your intracellular tau tangles. We call them tangles because they contain lots of different fibrillar structures that all get tangled together. Okay, let's move on to Lewy pathology. So Frederick Lewy, around the same time as Dr. Alzheimer described Alzheimer's disease, he described these structures that he had identified in postmortem brain. And they were called Lewy bodies, is what he named them. And what are Lewy bodies? So Lewy bodies are, again, they're aggregates of misfolded protein that accumulate inside the neurons in the brain, inside the nerve cells. And one of the primary proteins that's found in a Lewy body is a protein called alpha-synuclein. And that's most of my research for my career has surrounded investigating what's going on with alpha-synuclein and how does it end up accumulating into a Lewy body. If you look in a postmortem brain section, this is what you'll see. And if we zoom in a little bit more, this is what we're calling a Lewy body. So Lewy bodies are aggregates that contain misfolded alpha-synuclein, and they accumulate in the brains of patients, inside the cells in the brains of patients who have diseases such as Lewy body dementia or Parkinson's disease. And so if we take all this together, what we also can say is that Lewy body dementias are also sometimes referred to as alpha-synucleinopathies. And we call them alpha-synucleinopathies because the major protein that accumulates in the brains is called alpha-synuclein. So what is alpha-synuclein and what does it do? Well, alpha-synuclein is in all of our cells in the brain, and it actually has a normal function in the brain. So if we think about how cells talk to each other in the brain and how messages are transmitted from cell to cell and from one region of the brain to another, and from the brain down to your muscles and your heart and your peripheral organs, then the neurons in the brain talk to each other by using a connection called synapses. And a synapse comes from the end of a terminal of one neuron, touches a region of the next neuron. And so let's just zoom in a little bit on this region here that we call the synaptic terminal, and that's below. And in the synaptic terminal, you have the region that comes from the neuron that's sending the signal, and then you have the region of on the neighboring neuron that's receiving the signal. And we're going to zoom in a little bit on this, what we call the presynaptic terminal. Here's your presynaptic terminal, and this is where alpha-synuclein has one of its major functions in the cell. So one of the ways that neurons can send their signals is called via a chemical synapse. And what that means is that the neuron releases neurotransmitter chemicals from its synapse that then travel across this little space in between called the synaptic cleft and have an effect on the neighboring cell. And alpha-synuclein is involved in regulating the vesicles, or the small little bubbles that contain the neurotransmitter that then that are cycled along the synapse. They then merge with the cell membrane, they release their contents, and then those vesicles or those little bubbles are recycled. And alpha-synuclein plays a really crucial role in recycling these vesicles within the synaptic terminal. But when alpha-synuclein is not functioning properly, it becomes dissociated from these vesicles. And that's when we find that it gets aggregated and it gets deposited into Lewy bodies in the brain, and it's no longer available to do its normal function. One other thing I want to tell you about alpha-synuclein, which is important to what we're going to talk about, is that even though alpha-synuclein is found inside these neurons, inside the nerve cells in the brain, it can also get outside of the cells. Now, we're not really quite sure right now how it gets outside of the cells and why it gets outside of the cells, but we do know it can be found outside of these cells in the brain. What we think is happening is that alpha-synuclein can be released either in a small vesicle that we call an exosome, or that it can be just directly released from the cells, or that it can be released as a function of the cells trying to get rid of proteins that it doesn't want, again, in a kind of vesicle called an exosome. But regardless of what it's doing out there, we know that it is important that it's found in the extracellular space, and we believe this plays a major role in how the diseases like Lewy body dementias and Parkinson's disease can actually progress and get worse over time. So let's talk a little bit about disease progression. So as I just told you, we think that alpha-synuclein can get outside of the neurons, and we think that alpha-synuclein can spread from neuron to neuron in the brain. And we think that the spreading of the alpha-synuclein actually corresponds to the disease progression as well as the severity of the disease symptoms. So if we think about where alpha-synuclein aggregates are found in the brain. So when the Lewy bodies are, and the synuclein pathology is kind of restricted to the brainstem region or the olfactory bulb region of the brain, that's usually very early in a disease process. But what we do know is that as the disease progresses, these Lewy body pathologies seem to spread throughout the brain, such that really in the end stage of disease, the Lewy bodies are found all over the brain. Now, when the Lewy bodies are restricted to the brainstem, we actually associate this more with the clinical diagnosis of Parkinson's disease, because mainly the motor regions of the brain are being affected by the Lewy body pathology. However, Parkinson's disease dementia and dementia with Lewy bodies, if we examine the brains of patients who have had these disorders, what we find is that we find the Lewy bodies not only in the brainstem regions, but also in the limbic regions and in the cortical regions of the brain as well. And as the Lewy body pathology has spread throughout the brain, the patient's symptoms have correspondingly got worse. So how does the Lewy body, where does it come from? Where does this Lewy body pathology come from? Well, there's still a lot of unknowns, unfortunately, but we do know that there's two different ways that we can think about this. And the way that they think about it is some people call it body first and some people call it brain first. And so we think there's two different ways that the Lewy body and the alpha-synuclein aggregates can accumulate in the brain. Now, in the body first scenario, it's actually thought that Lewy body pathology could actually start in the enteric nervous system in the gut, and that the Lewy body pathology spreads via the vagal nerve up to the brain. And then from the brainstem, it proceeds to spread throughout the brain. Conversely, in the brain first hypothesis, what they think is that the Lewy body pathology perhaps starts in the olfactory bulb. So this is the region of your brain that's responsible for synthesizing smells and what you're smelling in the environment. But if it starts in the olfactory bulb, then it tends to spread throughout the brain first before it spreads down into the peripheral organs. When we think about Parkinson's disease and Parkinson's disease dementia, now, as I said before, Parkinson's disease tends to very much have the Lewy body pathology restricted to the brainstem region or the olfactory bulb region. And so the way I kind of think about it is perhaps Parkinson's disease patients are more of a body first type pathology, where it started in the enteric nervous system, in the gut, and then it spread via the vagal nerve up until the brain. Now, patients who present with dementia as their first symptom are often diagnosed with dementia with Lewy bodies or Alzheimer's disease. And in those cases, perhaps it's more of a central pathology spread, starting in the olfactory bulb that then moves throughout the brain before into the periphery. Now, these are all hypotheses. We do not know the actual answers to these questions yet, but it's kind of interesting to think that there may be different things that precede the start of the pathology in the brain. So then let's talk about what pathologies are actually in the brains of these patients. So Lewy body dementia, as I've told you, is an alpha-synucleinopathy. So we know that it has Lewy bodies in regions of the brain, inside the cells. But we also know that most people with Lewy body dementia also have beta amyloid plaques in the brain. So conversely, Alzheimer's disease dementia is known primarily because of amyloid plaques and neurofibrillary tau tangles that are found in the brain. But what's really confusing and interesting at the same time is that about 98% cases of Lewy body dementia in the brain bank at Mayo Clinic also have tau tangles, and that about 50%, 40 to 50% of the patients that were diagnosed with Alzheimer's disease, their brains also have Lewy body. So we have all of these what we call comorbid pathologies that are occurring in the brains of patients. But both of these disorders present with cognitive impairment. There are also other symptoms which sometimes are in common with the disorders, but sometimes are more one disorder versus the other. For example, Alzheimer's disease and Lewy body dementia both can have neuropsychiatric symptoms, whereas Lewy body dementias more commonly have sleep problems, they suffer from visual hallucinations, and then often have Parkinsonism, which is more of when their movement and their motor function is affected. Whereas in Alzheimer's patients, they also often present with more of a confusion or having trouble with language as their primary symptoms. So as you can see, there's quite an overlap in the main symptom that both of these diseases present with, which makes it quite challenging, I think, sometimes for clinicians to give an accurate diagnosis. Now, if we look at Lewy body dementia symptoms, there are a whole host of symptoms, and these symptoms correspond to where the Lewy body pathology is actually occurring in the brain, as well as where the amyloid plaques are in the brain and where the neurofibrillary tangles are in the brain. And so very commonly, as I said, patients will have patients with Lewy body dementia have cognitive disorders. They often have sleep disorders, neuropsychiatric symptoms, motor symptoms, and autonomic symptoms as well, such as constipation and urinary incontinence. So how do the clinical symptoms of Lewy body dementia and Alzheimer's disease, how are they the same and how do they differ? Well, dementia with Lewy bodies, which is one of the Lewy body dementias, has several core features that clinicians look for when the patients come to see their doctor. So dementia with Lewy body patients also often have fluctuating cognition, which is in terms of attention and alertness. They usually have persistent and recurrent visual hallucinations. They may have REM sleep behavior disorder. And that often this REM sleep behavior, the REM sleep behavior disorder can often precede the cognitive symptoms in dementia with Lewy bodies. And then dementia with Lewy bodies, another core symptom or core feature is spontaneous motor features that are similar to those seen in Parkinson's disease, such as tremor or slowness of movement. Now, there's other features that we associate with Lewy body dementias, and those are called supportive clinical features. And those could be that patients who are suffering from repeated falls or fainting episodes. They could have severe autonomic dysfunction. So when I'm talking about autonomic dysfunction, we're talking about constipation or low blood pressure or urinary incontinence. They could have apathy or anxiety or depression. Sometimes they have a loss of sense of smell, and sometimes they have excess sleepiness or hypersomnia. Now, both dementia with Lewy bodies and Parkinson's disease dementia are called Lewy body dementia. So how are these discriminated by a clinician? Well, the way the clinician discriminates between whether they say a patient has dementia with Lewy bodies or Parkinson's disease dementia is based on the timing of the dementia onset relative to the timing of the motor symptom onset. And so they call it the 1-year rule. So dementia with Lewy bodies is usually diagnosed when the dementia occurs first and either at the same time or within 1 year of the onset of the motor symptoms. So you could have motor symptoms first, but if it is closely followed with dementia symptoms within a year, that would be indicative of having dementia with Lewy bodies. Contrast, a patient who has motor symptoms first and develops dementia symptoms with more than 1 year after the onset of the motor symptoms is usually diagnosed with Parkinson's disease and then Parkinson's disease dementia. So it's really quite an arbitrary rule if you think about it. It's just this 1-year rule in what your diagnosis could be. However, as we strive to get better diagnostic techniques and have biomarkers available to help us diagnose these diseases, this will become hopefully more of a science than just a 1-year rule. So then a patient will receive a diagnosis of probable dementia with Lewy bodies if they have 2 or more of the core feature I described, or they have 1 core feature and 1 what we call indicative biomarker. And I'll talk about those in just a minute. Whereas a possible diagnosis of dementia with Lewy bodies can be given if you only have 1 of the core features, or you have 1 or more of the indicative biomarkers, which I'll talk about in a minute. And maybe you don't even have clinical features or clinical symptoms at that point. All right, so how does this differ from Alzheimer's disease symptoms and features then? Well, the core features of Alzheimer's disease are memory impairment with a specific type of memory called episodic memory being affected. Patients also often have impaired executive function, which refers to their judgment or problem-solving ability. They may have problems finding the right word. So impaired word finding is another core feature of Alzheimer's disease. And then sometimes behavioral or psychological symptoms such as irritability or apathy can also be a core feature of Alzheimer's disease. And then the supporting features of Alzheimer's disease are things like what we would call apraxia, which is difficulty performing a task that you've done many times before, or perhaps hyposmia, which is a loss of sense of smell. Sometimes there are sleep disturbances associated with Alzheimer's dementia, as well as this symptom called myoclonus, which is when the patient gets these small, uncontrollable jerking movements. So as you can see, some of these are in common with dementia with Lewy bodies and Parkinson's disease dementia, but others seem to be unique to the Alzheimer's disease dementia. Now, when it comes to diagnosing Alzheimer's disease, the clinicians have really a battery of tests that they have access to. And these days, in recent years, we've had many advances in imaging. So in amyloid PET imaging, which is a form of MRI, which can be used with a radio tracer, and we can actually detect the deposits of amyloid beta that are happening in the brain outside of the cells. We now also have tau PET tracers, and those are similar imaging, but they're using a radio tracer which binds to these aggregates of tau, and so that you can see them in the brain after imaging. We can also take cerebrospinal fluid, so do a spinal tap or a lumbar puncture, and if you take the fluid from the spinal cord, you can measure levels of amyloid beta. And if you look at the levels of amyloid beta, they're different in patients with Alzheimer's disease than they are in patients who don't have Alzheimer's disease. And lastly, we now have a biomarker. And when I say biomarker, I mean something that we can actually measure that tells us something about the disease or the disease process, or if the disease is present. And so now we can actually take a blood sample and we can measure levels of this protein tau in the blood of patients with Alzheimer's disease. And if a certain type of this tau protein is present, it's indicative of Alzheimer's disease. But there is a challenge that faces us diagnosing Lewy body dementia because we don't have the same access to the same types of biomarkers for Lewy body dementia that we have for Alzheimer's disease dementia. There are some biomarkers available that we're calling indicative biomarkers. So they haven't yet been developed to the level where we can call them diagnostic biomarkers. Nonetheless, there are forms of imaging that can give us hints to what's going on in the brain. And so there's a thing we call dopamine transporter loss. So dopamine cells are often affected in Lewy body dementia, or cells that produce the neurotransmitter dopamine. And so we can look at the dopamine levels in the brain. We can just look at the overall structure of the brain using an MRI. As I said, often patients with Lewy body dementia have had REM sleep behavioral disorder. And so by sending them for a sleep test, we can sometimes detect this RBD. And then there is another test that sometimes is done, less commonly in the United States, more commonly in Asia actually, but it's called the cardiac sympathetic denervation test. And that often can also give a hint to whether a patient has a Lewy body type dementia. There are also what we would call supportive biomarkers, and these are things like the activity that's going on in the brain, or as I said, we can measure proteins in the CSF. Now, we don't have proteins that change as much as the amyloid beta in Alzheimer's disease, so we're still trying to develop the proteins that we're looking for in the brain that can tell us that somebody has Lewy body dementia versus Alzheimer's disease. And hopefully that's something that's really coming down the pipeline now and will be available in the years to come. And then we have some emerging methods of detecting Lewy body dementias. And these emerging methods are based on trying to detect that protein alpha-synuclein that aggregates in the brains of people with Lewy body dementia. And we'll talk a little bit about one of these emerging methods as well. So, as I said, we have lots of opportunities to try and develop better biomarkers and diagnostic biomarkers for Lewy body dementia. And we can use sources, things from all over your body to try and develop these biomarkers. We can actually think about using brain biopsy tissue, although this would not be our first choice, obviously. But we're trying to develop tests in the blood. We're trying to develop tests using spinal fluid from the CSF. We have some tests that can be done on skin tissue. People are trying to develop tests that could be done from the urine or perhaps from saliva. And so these are all opportunities to develop biomarkers to distinguish the Lewy body dementias from Alzheimer's dementia. And many of them are under clinical testing and under development as we speak. Let me just tell you about one of these. It's called the Synuclein-1 study. And so what this actually is actually based on a skin biopsy, where they take a small region of skin that goes through the several layers of your skin, including the epidermis and the deeper dermal layers. And if somebody takes a skin biopsy from a certain region of your body, they can then use an antibody, which is a tool that can detect a protein. And so we have an antibody that can specifically detect a special form of alpha-synuclein that's associated with the disease. And we call it phosphorylated alpha-synuclein. And what this study showed that if we take skin biopsies from patients with multiple system atrophy, which is another alpha-synucleinopathy, or Parkinson's disease, which is, as I said, is a synucleinopathy because they have Lewy pathology, or we take skin biopsies from patients that are healthy or healthy controls in this case. When they looked for this type of alpha-synuclein, this phosphorylated alpha-synuclein in the skin, they were able to see that 100% of the patients who were diagnosed with multiple system atrophy had phosphorylated alpha-synuclein in their skin. And almost 95% of the patients with Parkinson's disease had alpha-synuclein in their phosphorylated alpha-synuclein in their skin. And none of the healthy controls that were tested had phosphorylated alpha-synuclein in the skin. And so this is one biological biomarker test that's actually being used in the clinic at the moment. It's just starting to become more widely accepted. But this is one test that will be able to tell you if you have this phosphorylated alpha-synuclein in your skin, and then potentially be able to tell you if you have an alpha-synucleinopathy. But right now, I don't think this test is sensitive enough that we could say whether you have a synucleinopathy, which is Parkinson's disease, or a synucleinopathy, which is multiple system atrophy, or a synucleinopathy, which is dementia with Lewy bodies, or Parkinson's disease dementia. It just identifies the fact that there's an abnormal alpha-synuclein in that patient. So then why is it important that we have biomarkers to try and diagnose these disorders? Well, I think it's really important as we get more and more treatments becoming available that we're able to give an accurate diagnosis for these disorders. The treatments that are available will be able to be tailored to what the diagnosis is. It's also really important to give the patients an outlook or a prognosis about what's ahead of them, which is important for their caregivers as well as we help plan their care that they're going to need over the coming years. So it's really important for patients and families that they get an accurate disease diagnosis when they come to the clinic. And one of the challenges so far has been accurately distinguishing dementia from Lewy bodies, which is a Lewy body dementia, from Alzheimer's dementia. And nowadays, we actually have some therapies that are available to treat Alzheimer's dementia. And these therapies may also be useful for treating dementia with Lewy bodies. But we do need to have accurate diagnosis because there are some treatments that are available for Alzheimer's patients that would not be good to give to patients with dementia with Lewy bodies or certain types of Lewy body dementia because they maybe have adverse effects in that patient population. So just to finish up, I'm just going to mention a couple of the studies that are actually in clinical trials right now. There are currently some phase 2 trials ongoing, looking at different ways to treat dementia with Lewy bodies or alpha-synucleinopathies. And then there are many other studies that are currently planned, including some of the anti-amyloid immunotherapies that you might have heard about that have recently been approved by the FDA for Alzheimer's disease, and they are now entering clinical trials for some of these mixed disease dementias. And by that, I mean these dementias like Lewy body dementia, where they have changes in the brain that are associated with both Lewy bodies and amyloid plaques and tau tangles. And so I think there are many reasons to be optimistic in the field. And from the view of a scientist, we have very much a lot of optimism for developing new biomarkers for the disease and new diagnostic biomarkers to distinguish dementia with Lewy bodies from Alzheimer's disease. We will admit there's still gaps in our diagnostic capabilities. However, and that's often very true sometimes when you have patients that present that maybe just don't have the typical symptoms that you would normally see. But there has been major advances in developing biomarkers, especially those that are based on our biospecimens. And by that, I mean the cerebrospinal fluid or the blood or the urine. And there is still a lot of room for improvement, and we still need to have biomarkers, which we would call non-invasive, so maybe it can be done from blood or saliva, which are routine body secretions to be collected, that are also inexpensive, so that the medical insurance companies will pay for them, and that are accessible to all populations, no matter where they live in a large city with access to really great medical care, or whether they're in a more rural part of the United States. And so it's really important that we continue to develop these biomarkers to make them inexpensive and accessible to all parts of the population. And so we continue to explore the alternatives that are available to us right now. And in my lab as well, we're continuing to look at developing biomarkers that would perhaps use samples from the blood or stool samples or saliva samples to come up with biomarkers, good biomarkers, that we can diagnose dementia with Lewy bodies or Lewy body dementias early in their disease process, rather than later when the symptoms are much further along. And so with that, my time is up and I'm going to stop. And I just want to say thank you for your attention today. I want to say thank you to the Lewy Body Dementia Association for inviting me here to talk to you today. And I hope you have learned a little bit about what's common and what's distinct between Alzheimer's disease and Lewy body dementias. And I would just like to thank all of the patients who donate samples out there, who donate blood, who donate CSF, and who eventually, upon their passing, donate their brain, because without these crucial biospecimens, we could not move the science forward. And then I would just like to give a thank you as well to the many organizations that can support my research and the research of many other research labs in the United States. So thank you very much for your attention.
All right, looks like we're getting some looks like we're gonna give some reactions for your presentation here. I'm seeing lots of hearts and thumbs up. Pam, thank you very much. It was a really great presentation. We do have a number of questions, which for some reason just disappeared on me, but I think I can find them again rapidly. All right, here we go. So one thing before we jump into the questions, I do want to mention just to the audience, Dr. McLean mentioned a few ongoing clinical trials right now. There's another one actually that we didn't mention, but is also ongoing. It's called the Rewind LB trial. And it's similar in some ways to the Shimmer trial, just testing a different investigational medication that works through a different, what we would call mechanism of action. So you can think about that as like, Tylenol and ibuprofen both being pain relievers, but working in different ways. So I did want to briefly mention that as well, because we expect top-line results, meaning how well did the drug work or not work in these clinical trials. We expect to hear the top-line results from that either sometime in December for both of these trials or sometime in January. So please be on the lookout for that, because as soon as we get the results from those trials, we will be sharing them out with the community to keep you informed of what's happening in research. So we're actually going to turn to the Q&A now. And so we got a number of questions here. Some of them are on very similar topics. And so if you don't hear me read your question exactly as you wrote it, I might be combining it with another question, or I might be just rewording it slightly so that it's a little more relevant to everyone else who's on the webinar with us today as well. So let's jump in. Dr. McLean, how common is it for a person to have the brain changes associated with Alzheimer's disease and the brain changes associated with Lewy body disease at the same time?
So let me start by saying that we don't know until a patient has passed away what the brain changes in the brain look like. We don't have any way to detect them. Actually, that's not right. We have some ways to detect some of the changes, but we don't have ways to detect all of the changes. And so a Lewy body dementia is Lewy body dementia because they have changes associated with having amyloid plaques. They also have Lewy body pathology, and they also have tau tangles in their brain. Now, there are additional changes that I didn't talk about today that they could also have. And so it's very common, I would say, for Lewy body dementia patients to have all three of those changes in their brain at the same time. Now, we don't know which one comes first. We don't know if one causes the other one to appear. We don't know if they all come at the same time. There's still a number of unanswered questions that we're working on scientifically to try and get answers to.
And those are really important questions scientifically that I know people like you and your colleagues and others are working diligently every day to come up to find answers to those questions. Here's another one about PET scan, and I think you probably discussed a couple of different kinds of PET scans today. So the question is, can LBD be diagnosed by a PET scan alone?
And the answer right now is no. So ideally, what we would like to be able to do is to have a PET scan that so let me back up, excuse me. So we have PET scans that can detect the amyloid plaques in the brain. So they can say how much amyloid a patient has building up in their brain. And we have PET scans that can detect the tau tangles in the brain. We do not have a PET scan right now that can detect the Lewy pathology. And actually, there are multiple companies working on trying to develop these agents that we can use to detect the Lewy pathology with a PET scan. So right now, you could, let's say a patient has Lewy body dementia and has a PET scan for amyloid. They will very well have a positive PET scan for amyloid because I've just told you that Lewy body dementia has amyloid plaques and Lewy body pathology and tau tangles. But we don't have one PET scan that can distinguish between these diseases. I think if we can have a Lewy PET scan as well, that will certainly move the field forward and will make PET scanning. So I don't think that you will ever just take a PET scan and that will be the only test that you get. The PET scanning is also combined with other readouts, other biomarkers that we measure in the blood or in the CSF. And so it's really a combination that we take because you really want to have a strong confidence in the diagnosis. And so even for Alzheimer's disease, a PET scan is not enough. You have to combine the PET scan with the cognitive assessment and the clinical assessment, as well as the blood biomarkers and the CSF biomarkers.
Yeah, so unfortunately, not a single test today, and probably not a single test in the future, although we don't know, certainly what the future holds. We had a question here about, I'm actually going to skip that one because this is a question related to the SIN1 test, but it came in before your slide on that. So I think, the question is, will you be discussing the SIN1 test? And I think the answer was yes. So we're going to consider that one answered. This is an interesting one. So this is related to the body first versus brain first, where Lewy bodies can start in the gut and then potentially spread up to the brain. And the person is asking, what kinds of symptoms should a person notice? And I know you mentioned there are lots of different domains of symptoms that people might experience. So maybe you could talk a little bit more about some of those, and in particular, what you might see with gastrointestinal or gut-related issues.
So I'm actually going to use Parkinson's disease as an example here. So Parkinson's disease patients often, before they realize they have Parkinson's disease or before they're diagnosed with Parkinson's disease because of the movement disorder that they often have gastrointestinal and symptoms that have preceded their motor symptoms, sometimes by decades. And what we're talking about there is things like constipation, so slow movement through the gut, which causes constipation, is often associated with is often a symptom that can be associated with Parkinson's disease patients. Now, the problem is hindsight is 2020. And so when somebody receives a diagnosis with Parkinson's disease and their doctor asks them, well, have you been experiencing any symptoms of constipation? They might say, well, yes, I've had constipation for the last decade. But when you have constipation, that doesn't mean you're going to develop Parkinson's disease. And so some of the body first symptoms we talk about could be associated with having Lewy pathology in your enteric nervous system, in your gastrointestinal system. However, it hasn't been directly linked to constipation in these diseases being caused by Lewy pathology in that region of your body. We don't know yet if that Lewy, if the presence of misfolded alpha-synuclein in your gut is actually causing constipation in those patients. Does that answer
Yeah,
the question, do you think, Keith?
I think it does, yeah. And the other thing that that I'll just mention there is there are many, many reasons a person could have constipation, right? And so if you are experiencing constipation, you need to get that checked out by a doctor in case there's a really benign reason for that they can help you with right away. And it does not necessarily mean that you're on the way to Parkinson's disease or dementia with Lewy bodies. But certainly looking backwards, like you said, many people who do end up having Parkinson's disease or DLB, they did have constipation earlier. So great, thank you. Let's see. Other questions. Oh, this is a little, kind of unexpected, and I don't know if you're going to have an answer to this. I certainly don't, and I don't know if science has an answer to this yet. So maybe you do, or maybe this is an area that all of medical science just hasn't figured out yet. But the question is about the involvement of LBD. Ooh, did I lose it here? Oh, here it is. Okay. So the question was about, synaptic involvement in LBD, but the question really is, do people who have ADHD, are they at a higher likelihood of developing LBD?
I don't think there is an answer to that question. I think you're right, Keith. I don't know if anyone has looked at the instance of ADHD in Parkinson's disease patients or Lewy body dementia patients. Now, part of that is maybe where we are because as our population is aging, these diseases, Parkinson's disease, dementia with Lewy bodies, Alzheimer's disease, these are primarily diseases of aging. And I will say, at least in the way I think about it is that ADHD is much more commonly diagnosed nowadays than it was 30 or 40 years ago. And so with the current patient cohort that we have who are diagnosed with Parkinson's disease or Lewy body dementias or Alzheimer's even, their doctors, maybe when they were children or young adults, were not even looking for ADHD. So we may not even have the data to be able to make that comparison right now. Um, I think in the future, obviously, this is as people, younger people now are aging and are being afflicted with these disorders, maybe that's something we will be able to correlate in the future. But right now, I don't think we have an answer to that question.
Great, thank you. Yeah, I'm not aware of one either. I haven't seen anything in the literature about that. This is an interesting question. This is about life expectancy. Is there a difference in life expectancy in people who have Alzheimer's disease versus Lewy body dementias?
Yes, I believe so. I will caveat this by saying I'm not a medical doctor, and
Yes.
I, to the best of my knowledge, I will answer the question. My understanding is that when a patient who has dementia with Lewy bodies, if they also have amyloid plaque pathology, which they mostly do, they will, and if we then compare them to a patient who has Alzheimer's disease, who has just amyloid pathology, I believe, actually, I'm going to back up. I'm going to answer this differently. If we look at Alzheimer's disease patients, patients who have only amyloid pathology versus an Alzheimer patient who also has Lewy body pathology, which, as I said, occurs in about 40 to 50% of those patients. I believe the patients that have the concurrent Lewy body pathology progress faster and so have a much shorter disease duration or a much faster progression. Now, unfortunately, because we can't detect the Lewy bodies in the brain, we can't detect the Alzheimer patients who have the Lewy body pathology concurrently at the moment.
Yeah. I think we have, thank you for that. And I think we have one more time for one more question here. And this person is asking about DAT scan. Can you tell us anything about the role of DAT scan in identifying people with LBD?
Right. So DAT scan is actually very informative when we're looking at patients who have Parkinson's disease. And I know I keep going back to Parkinson's disease, but I think what happens in a Parkinson's disease patient can inform us very much about what's going on in dementia with Lewy bodies and other Lewy body and Parkinson's disease dementia, obviously. So DAT scan is traditionally used as part of the diagnosis, I think, of Parkinson's disease, because Parkinson's disease patients primarily lose the cells in a region of the brain called the substantia nigra, and these neurons in that region produce the neurotransmitter dopamine, and dopamine is very much involved in helping you execute motor function. And so when these cells disappear, we get a loss of what's called dopamine transporters. And so they can measure, the DAT scan measures the uptake of dopamine in the brain. And so if you don't have enough dopamine transporters, you get less dopamine uptake. And that's what shows up in a DAT scan. And I'm probably not explaining this very well, but
Yeah, it's quite all right. I actually think we have a webinar from earlier, either this year or last year on DAT scan.
okay, great.
So Rose, if you can recall this when we send out the follow-up email to this webinar, if we can find the link to that one, that might be a good one to put in as a resource in that email. All right, so we are almost out of time here, so I'm going to say thank you to Dr. McLean for joining us today. And then I've got a few kind of housekeeping things to wrap up with. So first of all, on behalf of LBDA, I'd like to thank all of you for taking the time out of your day to join us here and thank Dr. McLean for sharing her knowledge with us. Also, as a reminder, again, in about 1 week, you're going to receive an email with the link to today's recording of the presentation and other resources and links that were mentioned in today's webinar. We do ask you to please take a moment to complete the survey that will launch right after you leave the webinar today. And again, that does help us inform our content for 2025. On behalf of all of us here at LBDA, thank you again for making this year's entire webinar series a huge success. This is actually the last of the webinars for this year. And I would like to personally thank Julia Wood, who is our Director of Professional and Community Education, for the incredible amount of hard work and dedication that she put into doing 20 webinars in a single year. I'd also like to thank our marketing team, our research team, which I'm part of, and our support teams for all of their collaboration and working together on the webinar series. Also, to all of this year's presenters and panelists who shared their experience and their expertise with us through these webinars. And last thing I'll say here is thank you, all of you who have attended today, for being here with us. We've been really overwhelmed this year by the enthusiasm that you've shown for the webinar series, and we feel like we really couldn't have done it without you. It's just so motivating to see, the community show up and learn. So with that, I'm going to wish all of you a safe and happy holiday season, and we will see you again in the new year.